Our next panel is around health information sharing across the country. We're going to take a look at other states besides Michigan. Many states face common challenges, and some have developed very creative solutions to overcome those obstacles. This session welcomes speakers from coast to coast to provide insight into approaches taken by some of our sister states to solve the problems that we also face here in Michigan. Our first speaker is Deanna Town. She's Director of IT at the Department of Healthcare Policy and Financing at the Department of Health and Human Services for the state of Colorado. Ms. Town is with the Governor's Office, and she brings a diverse background to the role with extensive experience in project and portfolio management. Her role is responsible for working across the health portfolio to ensure the effective use of technology and to promote information exchange and sharing across the agencies. She serves on the Behavioral Health Transformation Council, the OIT Architecture Review Board, and she is the chair of the OIT Emergency Response Council. Please welcome Ms. Deanna Town.
Hello. I have the joy of the first person you have to listen to after lunch, which is always great. So I was thinking of maybe singing, since that worked this morning. But lucky for all of you, my best friend of 30 years has informed me that I should never, ever, ever sing in public. So I'm going to let her know that she has saved all of you from me. If we can, thank you. I am excited to tell you a little bit about what we have going on in Colorado. It's been great to listen this morning because I think a lot of the challenges are the same across state lines as we would expect. I'm impressed with some of the things that are happening here in Michigan, and I would love to leverage some of that moving forward, but also to share with you some of the things we are working on within the state. So what are our challenges? They probably look really familiar, and I'm sure you could all write a book about them because we live this every day. But we obviously have a lot of problems with, or challenges associated with, laws and prohibiting data sharing, especially the laws that come out and say very specifically, you cannot share unless required by law, rather than you cannot share unless prohibited by law. That's a very different approach. It makes it very difficult. Data governance is tough for us too. So we have 17 agencies within the state of Colorado. As was mentioned, I'm the IT director for 2 of those, our Department of Human Services and Healthcare Policy and Financing. But then we also have a third health agency, which is our Department of Public Health and Environment. So we've taken something that's already difficult and spread it across 3 agencies just to make sure it's extra hard to work together. Technology, of course, we have the same challenge everyone does, especially with our legacy systems where we still have very basic data file transfers at the same time that we're trying to get to a much more mature data sharing level. And then relationships, just knowing who to be working with is always hard for us, especially as you broaden outside of just state government and think about Colorado's a home rule state. We have 64 counties. They act in many cases as the agents of the state, which makes it even more difficult and complex for us. One of the things we did to try to tackle this early on was create a Governor's Data Advisory Board, or the GDub. It's actually in our statute. It includes representation from our state partners, our county partners. We've got a couple of learning labs, specifically one from the university, or from DU, University of Denver. And we do have monthly meetings. And we decided to kind of take this approach, and we've really tried to mature it in the last couple of years because we have the statutory authority to do it, but more importantly, because we knew there was a problem, and we thought the best way we were going to solve it was at least getting people at the same table in the same room. We then built a roadmap. We started by adopting a technology standard. So we went and found our preferred enterprise service bus. We happen to be using MuleSoft. I know there are a lot out there. But the way that we're trying to push this now is making sure that as requests come in, our business analysts are trained when they're doing any kind of proposals or recommendations to think about data sharing at the beginning. So instead of kind of the old way of doing it where you build a system and then you think about, oh, what should this connect to? We're trying to make sure that it's built on the front end, ready to go. We obviously are pushing the same things that I'm sure most are with standard APIs. We want it flexible, scalable, and of course consistent. We've also worked and spent a lot of time across the agencies on building a standardized data sharing agreement. So we have one agreement now that is in place or is about to be fully executed among the 3 health agencies. So having that same language is now going to help us to be able to push that same standard template out to other partners that we're sharing with. What we found was that there was no consistency, that each sharing agreement was system by system, which made it really difficult. And that right now, we don't have data sharing agreements in place with a lot of our county partners or some of the other coordinating entities at the local level that we need. So our first step was, let's try to get the states, let's get our house in order. So we focused on getting a data sharing agreement across our agencies, but then the goal would be to start pushing that out. We also did a data dictionary and built out a data lexicon, which I'd be happy to share if anyone has interest in that. I'm not, if you already have one, that wouldn't be very helpful, but it took us months to get that piece done, just to get across our agencies agreement on what different terms meant and how we were using them was really important. We pulled up agreements that existed as well as compared it to some of our state statute and other federal regulations and tried to come up with, okay, when we say X, this is what we mean, and built a really kind of complicated matrix that then was pared down into a single document. And then we also started mapping data sharing restrictions by program. Well, to do that, what we found was step 1 had to be understanding what data we had and where we had it. So you can't do that effectively unless you understand exactly what data types are in each of your systems and then figuring out what applies at each level. And again, that's been very complicated and difficult, but we're slowly making progress through that. We also are continuing to work on information sharing and trying to engage our local partners as well as some of our nonprofits. So we're now in conversation with one of our local health information exchanges to procure identity resolution as a service through the HIE. What we found was we could go procure identity resolution as a service from any number of entities out there. You know, there are the leaders, kind of the Verados, there's Novak that's coming out. There are some really great tools and technologies, but we already had a partner in our health information exchange that had over 6 million identities fully resolved. Why would we duplicate that? It's not efficient, it doesn't make any sense. So we're trying to go down the procurement path and figure out how can we leverage something that already exists and break it outside of that kind of health-focused, medical focus, but recognize that a person is a person, whether they're coming in for a fishing license or we're trying to track what medication they're on. And the more that we can try to aggregate or compile that data or at least reference it across the systems, the better experience it will be for our citizens. We also are slowly migrating our legacy systems to better exchange mechanisms. So our problem is we started about, 3 or 4 years ago, I think, with replacing our MMIS. That went live last year. Now we're in the middle of modernizing our benefits system, which will go live the end of this year, beginning of next year. And we've got some of our major child welfare systems simultaneously going through modernization. Trying to sync those things up and make sure that we're building those kind of in parallel is really difficult, and especially because it's the same agencies asking for the funding. So going to our legislature and saying, you should give us $200 million in 1 year for us to do all these systems simultaneously won't happen. We've had to kind of phase it, and that's made it even more difficult to align and make sure they're all moving in the same direction. And then we end up paying catch up, unfortunately. The one project I really wanted to talk about for just a couple of minutes, we started a joint agency interoperability project in 2013. It's still underway right now. The whole goal of it was getting data to the right person at the right time for the right reason. What we were really focused on is we didn't want to build a big data warehouse. So we don't want to take the data from its data source. We want to leave it where it is, but be able to somehow build reference across those so that we can actually implement the use cases. The development of the use cases has been the hardest part for us. We can go buy an IDM solution. We could buy an identity resolution system. I mean, all of those things are easy. Figuring out what problem we were trying to solve, and so it was great in the panel before when it was mentioned, really understanding from the patient or from the citizen level what would add value and trying to drive use cases that way instead of just us trying to kind of smash these things together and move forward. We are really trying to do more of an analytics platform, obviously to try to get better services for our clients and to make things more efficient. You can see kind of some of the beneficiaries. I won't read them to you, but basically you can read the beneficiaries of what the Joint Agency Interoperability Project is intended to do. Again, I mentioned it started in 2013, so we're 5 years into this. I think we've learned a lot along the way, and the most important of which is that we needed to have done the business case development at the beginning. Struggling now to do that at the end has made this a really complicated project for us. This was our 2013 State of the State, primarily for our Department of Human Services. So you can see, I don't expect you to completely understand all the details of that, but what the graph is intended to depict is just how complicated each of those are data sources, those circles. So you can see how complicated it is and why it's taken us as long as it has to get where we're trying to go. Our future state is, this is another one that's kind of complicated, but just really focuses on, we needed to establish the basic foundational components, establishing governance, getting really common and consistent data language around all of our systems, understanding how we can leverage one or two technologies to move data around instead of kind of piecemealing it all over the place, and getting us really to think about data sharing as a framework within which everyone's going to operate, again, whether it's a health item or if it's our Department of Revenue who's issuing driver's licenses. Our timeline, I've mentioned a couple times it's been a long process, but I'll tell you one more time. You can see kind of what happened along the way. So where we're at right now is we have state funding, we have the state match, but need to submit another planning document to CMS for additional funding for the actual implementation piece. So we've been in planning for a very long time and now need to really transition that over. We do have RFPs drafted already for the technology components. Again, I think that's the easy, technology is the easy part. It's the processes and the people and the relationships that have really been the complicating factor. So my key summary points before I hand this over would be to be creative and look across programs for funding. We are trying to get as much done this year as possible because we have the A87 cost allocation waiver in place, allowing us to use that CMS funding for other programs. It has been interesting to try to look across other, like FNS, and some of the other program areas where federal funding is coming in to see how do we recognize that for social determinants of health, it goes beyond CMS. And oh, sorry, good morning, good afternoon. It goes beyond CMS and it goes beyond FNS and really needs to be kind of across all of those entities. And as we queue this up and get funding to invest the initial capital investment to put systems in place for data exchange, there's the ongoing cost component that if you don't have your federal and other state partners ready to step in and help you fund, you've invested a lot of money in something that's not going to go anywhere. And I will, one more thing. The heavy lift is up front. I think I've hit that a couple of times. And that data liquidity is the future. I don't think anyone will argue that we don't have to figure out how to do these things collectively and within each agency. It's definitely where we're headed. So I will hand this over.
Thank you so much, Deanna. We'll have some time for questions for both Colorado and New Jersey at the end. Our next speaker is John Novak. I have had the pleasure of working with John for the last several years. He's a Senior Director of Architecture and Government Technologies for the Healthcare Delivery Systems iLab at the New Jersey Innovation Institute. He's leading the core process and support team that implements appropriate controls to ensure stable and reliable service delivery to a rapidly growing staff and client base. As part of these efforts, Mr. Novak created technology and infrastructure roadmaps, established provisioning and onboarding processes for the organization. John has performed numerous IT infrastructure assessments and spearheads multiple projects related to health IT transformation and innovation, including the exchange of health information, master person index, and other value-based innovations. Please join me in welcoming John Novak.
Thank you all for having me. I decided not to do any slides because they would look a lot like Deanna's. As we go across the nation, we find there really is a lot of the same challenges. I'm going to take a slightly different approach. I'll go through a lot of things pretty quickly. I do have slides, and if you really want the slides, just let me know and I'll be glad to share them. The New Jersey Innovation Institute is actually part of the state's technical university, New Jersey Institute of Technology, which has been around since the late 1800s, and we've grown out of this organization. So why are we in healthcare? Well, back when high tech first came out, there was a group of people that came together trying to build an innovation institute at the university, and they said, hey, let's apply for this federal grant to help people get onto electronic medical records. They applied for the grant, and they got it. So over time, we were NJ High Tech, and we helped over 9,000 providers attain meaningful use in the state of New Jersey. As that started to roll down, we started looking at some other opportunities. We became a CMS registry, reporting over 300 different metrics. We support 17 of our local district hospitals to connect to health information exchanges and do their district data collections and submit their data. We also are involved in Physician Transformation Network, what we call the Garden State PCHEN, which is a CMS-led initiative. For 4 years, we were given $50 million to save the federal government $150 million. Up to this date, we've saved $136 million for CMS, 12 months ahead of our planned schedule. So we're very happy about that and very exciting. So we're very interested in healthcare and moving it along. The New Jersey Institute of Technology and the New Jersey Innovation Institute has the separate different iLabs, but we are focused on healthcare. We have since moved into, as I said, high tech and all these other pieces. About 5 years ago, the state of New Jersey came to us and said, this isn't working. We have allowed the state to develop on its own. At the time, we had 7 HIEs. Only 5 of those still exist. We've had 2 other HIEs now recently enter into the state, and one of the ones that went away because of failing technology and lack of investment has now come up as a local ACO. So we've seen a changing mix, but they came to us and said, we know this isn't working, what can we do? We took a step back with them, say, okay, if we connect these and we create an identifier for the state, where is that going to lead us? So we looked around the country, we saw what was working, what wasn't working, and oddly enough, which is one of the reasons we're here, we found Michigan. Michigan, while much bigger than New Jersey, was very similar, the number of hospitals, health systems, population. So we looked at what you guys were doing, and we adopted a lot of the technologies and infrastructure that Michigan did. So that led us to work with the ONC to develop an advanced interoperability plan for the state of New Jersey and do a pilot program. That was a 2-year program where we basically put in the core infrastructure, which allows us to do the core things that I mentioned before, establish the core network to connect our HIEs, to stand up a statewide master person index, not a patient, because as you were saying, it's not just about someone's in healthcare. We want to be, if they're checking their driver's license, we want to get there, that we have them uniquely identified across the state, as well as some of the core pieces of getting into some of the state registries. We initially started with the immunization registry, as well as communicable disease registry, and then also notifications on ADTs. As we've heard several times today, those are important. Those are some of the foundational plumbing in the system, but where do you take them from there? So we worked on our ONC project, 2 years. We have successfully completed that project as of the fall. We then took a step back with the state and said, okay, where do we go from here? Well, we get other people participating. So that was where we started to look at what is real and where do we want to be. So as we enter into our next phase, we kind of looked at our role as a state designated entity, which was to continue to operate the health information network, get all of our hospitals to participate with us, and not just participate by signing an agreement and doing nothing else. To us, this is about meaningful use of the data. If you're just receiving ADTs or just sending ADTs, you're not really doing anything. There's no outcomes. What do we do with this data once we have it? Making it useful, making it actionable is really what's important. So we're looking at how can you use this for transitional care management? How can you make it patient-facing? We have an immunization system, very good, very advanced. We can now connect to it and automatically submit through our New Jersey HIE platform, but there's still no consumer-facing side. So how do we put that consumer face to it, that a parent can go and look at the immunizations their child had instead of carrying around a little blue card that's all folded up and faded. So we want to make sure that we're working towards those items. Now, some of the challenges that we've had doing this are the ones that we've heard. Technology is always a barrier. Not that the technology isn't there. We've seen it, Carry Quality, Sequoia, Commonwealth, all the EMRs can all interoperate and they need to get there. But there's still a huge burden on those provider EMRs on their ability to connect and contribute data. Everyone go into a portal and look at data, but that's really not meaningful use. You want to be able to bring it down to the point of care and make that information usable for you. So that's one of the challenges that we're trying to do, and we think Carry Quality and Commonwealth really helps bridge that gap. Yes, as we heard earlier, there's a challenge, because if you get a document from a hospital, it has far too much information in it that you do have to go down to page 80 to find that one encounter that you're looking for. So we need to do some improvements. Within the state of New Jersey, we've had several challenges, as we said. The technology is the one. The legal agreements were another challenge that we saw. Not unlike Colorado, some of our departments are separated. Our Human Services and Department of Health are two separate organizations. So they don't communicate, they don't exchange data. They did do individual agreements every time they needed to exchange data, but they took a novel approach. We're in here putting in a statewide data sharing and reciprocal use agreement, or the DRSA as we like to call it. They're like, well, why don't we use that? So that's great. We're assigning trusted data sharing organizations within the state, whether they're an HIE, a hospital system, or one of the state entities. They can all participate in our shared common data sharing agreement and then participate in our individual use cases, which is going to hopefully really streamline going forward the ability for these agencies to exchange data and really move the needle. As we go in, our MMIS system is in the process of being upgraded, and one of the things as we're starting to connect, they have this onerous batch process getting data from Department of Health to Human Services. It's batch mode on both sides. It requires manual intervention. We have the infrastructure to do that automatically, but why don't we? Because they're too busy working on the legal sharing agreements. So we've taken care of that, so now we can focus on what the real issue is. The other one challenge we have is probably not uncommon, is the trust issue. And that takes several forms. Is what are you going to do with my data? Are you going to use it for something else? And this goes back to no, it's all specified in your legal use cases, and what are you going to do with the data, how you're going to use it, and what it can be used for. So that is a very big piece that we feel is moving the needle in the right direction, breaking that trust. The other piece we have on the trust side is there's a natural misconception that the HIN would replace an HIE. We don't persist data. We do not do provider portals. We do not do patient portals. We just want to make sure that the transport is in place, that when a provider needs a record from on their patient, wherever they are, as we heard earlier, we can get it there. And it's not a single button you can push. There's different technologies. There's different areas. It's where the data is stored. And we're looking to be that bridge to enable people to be able to do that seamlessly into their EMRs, and that's going to be a long road for us. And again, to try to keep this as brief as possible, I'll tell you some of the things that we're going to be working on in the near future, which are some of the typical things that you're seeing. Opioids is a big problem. We all know that. There are several aspects of that. One is, how do you get it into a physician workflow to be able to see if someone has an entry in your prescription monitoring plan? We're going to work on that notification. It's one of our key tenets for this year, is to make it that at a time of an ED admission is our initial pilot, that we will ping the PMP and return the record back to the provider at that hospital where that person is being seen. That'll move the needle slightly. The other piece of that is we're looking at the data. The Department of Health, Department of Human Services, EMS data, billing data, they have all this data, but yet every time we look at a report on opioids, it's 2013 to 2015 data. Why aren't we looking at data that's 3 to 6 months old? It's available within our states, and it has to be used. So we're working with our Department of Health and Human Services on how can we mine that data from their existing data sources. There's things that are just sitting on the shelf, like our EMS data, which has the administration of Narcan. And they have a very high percentage of people that are administered Narcan in the street that never get to the hospital. They refuse medical aid upon being revived. So that never makes into a hospital EMR and never hits a PMP. Yeah, that person's at a severe risk. So how do we take that data? How do we take coexisting conditions and make a risk score or a risk factor and be able to publish that out to providers. Those are some of the pieces around the opioids. Some of the other data is helping reduce inequities in care. New Jersey is one of the worst places in the country for maternal deaths. So from pregnancy to a year after pregnancy, we have one of the highest rates in the nation. We're not a third world country. That's unacceptable. And again, we have the data and we have the technology to address that. That's been one of the key pieces that we've been given from our Department of Health and our Commissioner of Health to help address within New Jersey. The final one that I'll mention, again, there is a whole slew of them, is the Commissioner of Health gave us the directive. He is a practicing emergency room physician that he wants the ability that if someone presents, he wants to be able to see that patient's complete record at the point of care. Medications, past history, allergies, and that's a pretty big challenge. That's what we're looking to do, and we want to take it. Now, also to put into the scope, and this is where I'll end the conversation, is we said we finished our pilot program back in the fall. Since that time, we have signed up 50 of the New Jersey hospitals. That's over 70% of the hospitals participate with us. And we've kind of taken a two-stage approach with that. It's participation and meaningful use. So in our case, the meaningful use is we want them to participate in our core use case, which is the plumbing, which is connecting and sending ADTs, and then participate in use cases. And we do not consider them adopters until they're participating in our use cases, whether that's opioids, notifications, or one of the other use cases such as immunization or some of the other ones that are coming up, then they are useful. And that's where we really see, because it's not about moving numbers. We can put all the transaction numbers we want out there, but this is about improving outcomes and changing population health. So that's what we're aiming for. That is the tenet that we're getting and the direction from our Department of Health and Human Services, and that's our goal at this point. And I'll turn it back to you, Shelley.
Thank you, John. All right, so with that, we'd like to open it up to you for any questions that you have for our panel.
Thank you very much for your presentation. I have two questions. First one is, physicians are a competitive lot, but we share readily. If a practice came down the street to my office and say, hey, what are you doing in this? We would easily share and give information to them because we don't feel like we're competitive in that way. I'm just curious what you think is, how do states collaborate? Are states competitive with each other? Are they willing to share information? And then the second question, and more important, Deanna, I want to know who said the singing worked this morning, because that's the first time that everyone's ever said that. So.
I missed the second half of that question, and I have a feeling I would have liked it. So what was the second part of that?
Who said the singing worked this morning? That's never been said before.
Let's see, got it. For the state, we'll start with the state exchange question. Where we struggle the most in terms of sharing data is that we're organized with by department, and each of the funding, we're heavily dependent on federal funding. I think that that's a reality probably for most states, that there's a huge piece of that, and with that comes the requirements or regulations around sharing that data and very specific kind of boundaries. So we have a hard time even across our agencies. We have, one single Medicaid agency. It's our Healthcare Policy and Financing. We have another Department of Human Services that actually does a lot of the delivery, but also handles all the funding coming in from FNS. So we have challenges just across the different agencies within the state of sharing data. I know we have had some conversations, or some have taken place with other with other states regarding data exchange. At a very high level, I don't think we're at the level of maturity yet to be able to do that, but I'm hoping with the Enterprise Service Bus, as we move that effort forward, as we get a little bit more mature, that would be the next step. The problem most of the time isn't that people aren't willing to share data, and I don't even know that if we were to go out and ask patients how much they would care, because we don't have a lot of trouble getting consent for the most part. Where we do have problems, though, is when we're using, again, federal or even some of our state program dollars, then it brings that list of restrictions associated with it. So I think you're probably right. At the physician level, I suspect there's probably a lot more willingness. I think each layer you go up, the more difficult it becomes to share that information. So even some of our counties have been very successful at building out systems that pull data in from various data sources so they get that 360 view. We have multiple of those systems coming up within our counties, but again, I think each layer becomes more and more difficult. And sorry, Jen, I can let you answer that.
No, I would absolutely agree. As we see the same thing within our state agencies, there's not even to reluctance, but do they have the right to share the data? Also, the same piece when they're working with federal or state funding, they have to use those resources to get that work done, so they don't necessarily have the resource go out with it. And I do agree. I don't think there's a provider that wants to not share the data. It comes to with organizations that are concerned where the data is going to go and what's going to happen with it. And that is a challenge that we've seen. And it's also, you might want to, but how do you share the data? Do you have the technology to be able to move the data where it's needed, when it's needed to be? Or are you giving the person a CD to take with them to their doctor for their care? Or is it being faxed over? You know, we're at a point, the technology is there. We shouldn't be doing that.
I would add one more, because that spurred one more thought for me, and that's that we just had the IRS come in and audit, which anyone who's been through that, you know how much fun and how exciting that is. We are getting hit with audit findings because of ways that our counties are using the data or their physical security or their access control within the county facilities. All of a sudden, the state is now being held accountable and responsible for all of those situations, and I don't think that we fully understood that that would be the case, that we would be expected to go and make sure they have badge readers on their doors, and that they've got all of these other security processes in place. But we have pages and pages of findings. So I think at the same time that we're hearing from, and this isn't a criticism at all of our federal partners, I appreciate everything they do all the time, but at the same time we're hearing the promotion of interoperability, we have those situations coming, and it just makes it really difficult to figure out how to navigate.
Great question, thank you. Other questions?
So I'm just going to channel one of my friends from CMS, Tom Novak, who has been encouraging states and sharing with states that they can use 90/10 funding to enable sharing directly with the citizen, specifically Medicaid paid claims information like they did for CMS fee-for-service. And I'm curious if either of you guys got that on your roadmap at all, or are you still trying to be able to share with counties successfully, or where does the individual citizen come in as far as getting access to data held by the state?
Do you answer that first?
I'm not sure I heard all your questions, so could you just summarize and repeat that?
Sure. You familiar with Blue Button 2.0? CMS enabled fee-for-service Medicare beneficiaries, 53 million of them, to get access to data. SEMA Verma is encouraging states to do likewise. Is that on either of you guys' roadmap?
Okay, I just wanted to make sure I'm answering the right question. It absolutely is. One of the projects, first off, we have taken significant advantage of the IAPD funding and the 90/10 funding. One of the projects we're currently working on is consent management. That becomes, to go back to the previous question, of the part that I avoided or didn't really answer, was about the interstate communications. Is to us, that's one of the important parts, is to be able to get that consent. We are an out state. Our neighbor New York is an opt-in state, so it makes it a very huge challenge unless we have that consent. So we are absolutely currently working on an internal consent model, and we're putting in additional IPDS to help move along in furthering that, and the Blue Button is actually at the center of it.
And for Colorado, I would reference two kind of initiatives that are underway right now that do touch on more of the citizen experience. One is we received funding this year to start what we're calling My Colorado, which will be a citizen kind of a mobile app and enable them to access different state department systems right on their phone, just like most people would prefer to do these days, it seems. I know there have been conversations with our state Medicaid agency to try to kind of figure out how to fold them in the near future. So that piece is moving. We also do have what we call our Peak mobile app, which allows citizens to go on and apply for benefits. So try to get eligible for systems. That was heavily funded through CMS funding and through our state Medicaid agency as well.
Thank you. What other questions do we have for our other state colleagues? Nothing?
I know you guys can't see this bright, gigantic, shining light right at our eyeballs, so if it looks like none of us can see, it's because we can't.
It's the cheesecake coma setting in. There's one.
Hi, thank you for your presentation. My name's Alana Lara, and I'm with HIM State Government Affairs. I know that Colorado has recently launched a state health IT roadmap. So Deanna, I'm wondering if you could explain the benefits of this roadmap for data sharing between states and within states, if you recommend it for other states, and any challenges you've had developing that roadmap.
Sure. It was definitely led by our Office of eHealth Innovation, which is a great state agency partner of ours, and with our Department of Human Services and Healthcare Policy and Financing. The Health IT Roadmap really was intended to go outside of state government and really start looking at, more to the point of, all the way down to the citizen, but across all different levels. How do we start working towards one roadmap, one direction? The pieces that are included there in that roadmap absolutely overlap or align with the things that I talked about earlier. So focused on identity resolution as a service, or some sort of identity resolution. I think there's a clear recognition that if you can't figure that piece out, it's going to be really, really hard to do everything else. There's a big focus in there of replacing our legacy system that assigns identifiers across. It's called SIDMOD. It was built 30 years ago, very technologically advanced, as you would expect. But how do we start moving away from that? And that is a big piece that's within the Health IT roadmap. I think one of the key challenges with that has been people are busy. I mean, I don't think anyone has agencies where their staff are sitting there kind of twirling their thumbs saying, all right, what we should be doing are all of these things. We're tapped all the way out on resources, and the more that we try to be efficient with government spending, I think the more and more you see that there just isn't a lot of time for that innovation portion and that additional investment. To build new systems, a lot of times you're paying twice, because there's not a clear, sometimes you can forklift technology, sometimes you can't, but there's not an easy on-off switch where we say, today we're going to use this system, tomorrow we're going to use this system. In most cases, those two systems have to be supported for some amount of time in parallel. You're paying for both of them. That never goes over well with our legislature, as you would expect, and they certainly don't see the value in doing that, so that's been a challenge. But they were very supportive of funding the initial year of the Health IT roadmap, which I think says a lot about the direction we're trying to head as a state.
Okay, we have time for additional questions. Any? All right, John, Deanna, thank you so much.
Thank you.